16. So,
Okay, this I will tell this is 14 years old child. Please do cardiovascular examination.
okay, his name.
Name is Jack. No problem.
Okay, Jack. So, good morning. This is Dr. Noor, one of the children's doctor in this hospital. So after introducing to the mother and Jack, I will wash my hands and start examining Jack. So I want to look whether I will build rapport with him to see whether he's well communicating or not. I will check for distress, and I will also check for weight, height, head circumference, and plot on the appropriate growth chart for age and sex.
Yes, he's small for his age, and that's it. And you can see the picture.
Okay,
Yeah.
and now there are some unusual from the universal cue. There are some unusual features on his face, like depressed nasal bridge, upward slanting of the eyes, and round face. And also there are the ears looks to be slightly low set. With these findings, I think the face looks like a child of a Down syndrome. Then I want to check, is he attached to any cardiopulmonary monitors and anything in the surroundings?
No, just assume he's taking oxygen and he's having respiratory distress also. Bas.
Okay, then I will go for his hands to look for pallor, jaundice, pallor, clubbing, cyanosis, and any stigmata of infective endocarditis like splinter hemorrhages, Janeway's lesions, Osler's nodes.
Yes, you can see on the hand peripheral cyanosis, clubbing, and palmars are little bit red.
Okay, red palms. Okay, I will ask him to see the clubbing again to bring both the index fingers together. Then I will go for the pulse. I will check for the radial pulse for rate, rhythm, volume, character. Then I will also check for the radial delay on the other side, and also
Pulse,
femoral delay. Okay.
yes, there is no delay, but pulse is almost normal. Little bit tachycardia is there.
Okay, then I will check for, I will take his forearm and raise up to see for any water hammer pulse.
No.
Okay, then since he is 14 years, if there is any pubertal growth, I will just have look at the axilla, and also if there are any scars in the lateral thorax.
He just started.
Okay, then I will look for pallor and pallor in the eyes.
No pallor.
Mm,
No pallor, no
and in
jaundice.
the mouth, I will look for central cyanosis, pallor, and high arched palate or any other deformities.
No deformity, but he is cyanosed.
Okay, dental hygiene also I'll check.
Yeah, that is poor.
Then in the neck, I will check for visible pulsations, any visible pulsations.
No visible pulsation, no scar mark.
Okay, I will keep him in the, I will make him on the bed, I will keep him on the bed on 45-degree position and start examining the cardiovascular system. So inspection, I want to check if there are any deformities, scars, or any visible pulsations all around.
No scar, no visible pulsation.
Okay, then I will I will go for palpation. I will warm my hands and put both my hands on his chest to see if there is apex beat, where is force of the apex beat, and to know the character of apex beat.
Yes, apex is in the fifth intercostal space, just lateral to mid clavicular line.
Okay, then I will check for, I will palpate in all the 4 areas, that is the apical area and the left lower sternal edge tricuspid and the left and right upper sternal edges for pulmonary and aortic areas to palpate any thrill.
No, there is no thrill. Whatever, what else you want to palpate?
Any if the any palpable sound is there also, if palpable S1 S2 also, if anything is feeling, I will.
On the, yes, on the left sternal edge, there is palpable.
Okay, upper sternal edge,
Yes.
I will check. Okay, then I will want to auscultate in all the 4 areas: mitral, tricuspid, aortic, and pulmonary, to hear for any S1, S2 murmurs and the radiation of murmurs.
Yes. There is murmur, ejection systolic murmur on the upper left sternal edge. Okay. Yes.
Okay, then yeah, I would like to check its radiation. So is it radiating to the back? I would like to check.
No, it's not radiating.
Okay, then I want to auscultate the lung bases to see if there are any crepitations. And
Yes, there is no crepitation.
okay,
At
I
the
want
moment.
to check the abdomen for the hepatomegaly and lower limb for edema.
There is no hepatomegaly, there is no lower limb edema.
So in order to complete my examination, I want to take detailed history and take complete vital signs and take his weight, height, and plot him on the appropriate growth chart for age and sex, and take 4 limb blood pressure, 4 limb oxygen saturation, and check for any femoral scars and JVP. Your time finished.
Okay.
Okay,
So present your case.
today I examined Jack. He's a 14 years old boy. He is in distress on oxygen, small for age. He has unusual features on his face, going with Down syndrome. On my cardiovascular examination, he has apex beat palpable in the 5th intercostal space lateral to mid clavicular line, and there is a palpable second heart sound, and also a murmur, which is ejection systolic murmur in the left upper sternal edge, which is not radiating to back, and there is no thrill. With this finding,
Okay.
with these findings,
What will be your differential?
and also this child has cyanosis and clubbing. Okay.
Yes.
He can be a tetralogy of Fallot, which is not treated, or an Eisenmenger's disease.
Okay. What else can be?
Pulmonary hypertension, primary pulmonary hypertension.
So how will you diagnose?
So for diagnosis, I will do for him echocardiography, which will be the diagnostic investigation to look for the lesions of the heart and cause for his cyanosis and this murmur. And other things I want to do: chest X-ray, ECG.
Okay. What else?
ECG, echo.
So what will be on the ECG?
ECG, we may have this right ventricular hypertrophy, right atrial hypertrophy in the form of P pulmonale, and also right axis deviation.
Okay. Okay. So on the chest X-ray, what will be? You will find.
Chest X-ray, we can find a large heart because of the enlarged right ventricle. We can see the prominent right ventricle, and if it is tetralogy of Fallot, we can see boot-shaped heart. And also we can see the supply to the lungs is reduced, oligemia, or also the peripheral pruning, we call.
Yeah. Okay. So what advice you will give the parents?
I will give the parents to avoid the strenuous exercise, and also these children can have polycythemia. So to
Okay,
avoid
very good.
for high altitude, long staying high altitudes with strenuous exercises. And I will teach them if there are any cyanotic spells to the treatment of cyanotics, emergency management before
Like
they can.
dehydration and smoking, you will also advise.
Yeah.
Huh?
Yeah.
So what is the treatment final?
If this is an Eisenmenger disease, the final treatment will be of an uncorrected lesion. The final treatment will be heart-lung transplantation.
Okay. Before this lung transplantation, would you like to do some
Yeah, if the
treatment?
child has heart failure, I would like to give him some medications
Okay.
to control his heart failure. And if he has arrhythmia treatment can be given. And also
And
calcium channel blockers will help these children
yes,
with
so
some
you should involve multidisciplinary team
yes,
like special doctors. Always don't forget to tell that.
yeah, I will involve multidisciplinary team, the pediatrician, the cardiologist, and also since these children will have multiple problems, the endocrinologist and whole developmental team and the social support and the support teams and the educational healthcare plan will welcome.
Okay, that's good. So uh, you just forget only one thing. You did not ask about the I have written here where it is. Yeah, parasternal heave you did not check. Right
Because
ventricular heave.
they will have heaving pericardium.
Yes.
Yes, parasternal heave, I did not check. Yes.
Right ventricular heave will be there. Sometimes if it is very
Yes.
very significant, you can see the heaving
Yeah,
pericardium.
this is very significant. Sometimes they have click also, ejection
Yeah, they
click.
have
So
click
these two
also.
things,
Yes.
yes. Otherwise, that was okay. Viva was okay, but just don't forget, this is not our job. We will say that we will involve the multidisciplinary team, and the treatment usually will be this, like this.
Medical management also, you can just say sildenafil is trying before the.
Sildenafil can be
Nowadays,
given.
sildenafil is nowadays not used, right?
No, they are using.
They are using
Still,
because
some centers they are using,
They are
some
using.
centers they have changed
Sometimes
this
they are.
one.
Some of the institutes they are using, some they don't use.
Yeah.
In our institute, they
because
are using.
in the patient info it's written its use is controversial.
Yes.
Yeah. Still, this is not like it's not for like internationally everyone is using. This is still off label. I mean, they are using, some of the institutes they are using by their experience,
Off
by
label.
their research,
So we can mention it, you mean?
Yeah, it's written even in the mark. Medical management can be treated as, in the mark it is written there. Medical treatment involves use of pulmonary vasodilator as a sildenafil. It's written in the mark in their book. This means this is their book. And if it fails, that surgical option is only life-saving surgical option is, as you said, like heart lung transplant.
Yes.
Okay. So we will just say we will refer to cardiologist, or we can give.
Yeah, that's very important. As Dr. Adnan said, that this is
That,
not
yeah, that is very important. Always say
very
multidisciplinary
important.
team because this is not our job.
Our
So we
job,
will say
right?
that we will this child
Refer.
needs to be referred to multidisciplinary team in the form of cardiologist and dietitian, of course, and others associated with Down syndrome. Most probably he was following already for that multidisciplinary team. So I will include this and that, or don't say for Down syndrome they know, and then say most of the management is needs to, as the child is on respiratory distress and should be managed properly. For that, if the child is in failure, anti-failure medicine will be started, and if the child is having any arrhythmias, so that should be controlled, as you said, calcium channels and others. And as child, I am thinking of as Eisenmenger syndrome, that is pulmonary vascular disease, hypertension means. So that sildenafil is an option also, but this will be decided by the cardiologist.
Okay. So ultimately, here main team will come cardiologist and the
General pediatrics also, because he's Down
General
syndrome.
pediatrics, cardiologist, dietitian. But
Dietitian.
as the child is Down syndrome, so he may have other problems regarding associated with Down syndrome. So that maybe he's already following for that, but we will have to include that also.
Okay. So here, since there is reversal of shunt, there won't be any murmur of this VSD, no longer murmur of VSD.
No murmur, no
Yeah,
murmur. You will not hear the
that's
sometimes.
what I was thinking, that there should not be a murmur. Like if it is reversal is there, so murmur should be according to TR can be there. Okay. And
You know,
there
if
can
it
be,
is,
Not
you know, Dr.
TR.
Adnan,
Why
if it
TR
is,
will come here.
you know that if it is already like it's in the beginning, there will be murmur. But if it's like already shunt is reversed, right to left, there will be no murmur.
yes, that's I which I was thinking.
Yeah. This is it's written in the one of our cardiology book also, and here in the mark they put it ejection systolic murmur with ejection click and
Yes,
heaving pericardium. This is in the mark.
yes,
That
this
is
is
what
very,
I'm
But
telling
it's
you.
also
If it
it's
is,
also mentioned. Yeah, sorry, Dr. No.
go ahead.
It's also mentioned if they are like already shunt is reversed from left to right, left to right to right to left, then already they will not have murmur at that time.
yes, because if it is already shunt reverse, so there
No
should not be
murmur.
murmur.
It's a
There,
logic also. No murmur.
yeah,
Okay, so reversal of shunt here we don't have murmur, but
No
what
murmur.
happens here is now this is previously
Yes,
it
you
was
are right.
left to right.
No, this is left to right. First is this the one you draw first is left to right.
Left to right.
You will
Okay.
have murmur there.
if left to right is going, you if even if there is no pulmonary stenosis or anything, there is no, just VSD is there. So murmur can be of either VSD or you can feel a murmur of pulmonary flow,
Yes,
because
yes.
blood is going to directly there, but there will be no TR murmur is at this place. Why? I will tell you. This is very some people they are not understanding, because when this systole is happening in the left, the same time systole is happening in the right side,
Right.
just
Yeah.
a little bit difference. So the whichever the blood will come from the left side to the right, that will completely go to the pulmonary area.
Yeah,
So there
because
will be
we
no,
see this is what when it will come from left to right, it will not stay there. It will go through the
yeah,
pulmonary
so
up.
there will be no effect on the
Yes,
tricuspid.
yes, exactly. Yes.
But if there is reversal is there, so then this is bidirectional. This is not unidirectional. This is now bidirectional. Blood is
Yes.
coming from there also and from here also. They are mixing. There is too much pressure is there. So it should affect to tricuspid now.
Yes. Yeah, correct.
There is also two things here I want to tell you. Now what happened? Now this blue you are seeing, this is the reversal of shunt.
Yes.
Previously it was coming left to right, right?
Yes.
Now this is reversal of shunt. When it was coming left to right, what was happening was more blood was entering into this. So the more blood entering into this brought changes into the in the pulmonary vessel, like pulmonary hypertension. Okay,
Yes.
thickening of the vessel, and there is pulmonary hypertension. So what happens because of the hypertension now, more of the blood will stay here because more of the blood cannot enter into
Yeah,
this.
there is force also is there. So
Yeah,
there can be a chance of TR.
yeah. So what is happening? This is because it is working more. This is becoming big. This right ventricle, it is working more now to push the blood against the pressure in the pulmonary artery. So it is
Yes.
becoming, and also the blood which is not able to enter the pulmonary artery will go either in this reverse direction, and also some of the blood will enter into the right atrium, that is TR. And
Yes.
the right atrium will also become bigger here.
Yes, it
Yeah,
can be.
that's why in the ECG you can have a right atrial hypertrophy, right ventricle hypertrophy, and axis deviation.
Yeah, so
Yes.
P pulmonale, this is P pulmonale, and whenever we say about right ventricular hypertrophy, it is better to say tall R waves in V1 and deep S waves in V6. This is enough.
Yes.
Yeah, it's
Yes.
written there also in mark. Yeah, you're right.
Tall R waves in V1 and deep S waves in V6. If we tell this 2 point, it's more than enough, I think. And right axis deviation. Then what is the thing I wanted to do?
Peak also can be there.
pathophysiology there. And there is a chance of one more murmur to be heard here. What happens with this pulmonary artery is it becomes more broad as well, dilated. Okay. So when the pulmonary closes, there is some chance of leakage backward also here. This is pulmonary incompetence or regurgitation.
Insufficiency.
Yeah, you can hear same like a blowing murmur, how you hear in aortic regurgitation. Such a murmur can also be heard. Okay.
Yes, yes.
But
And also in ECG, you can get the.
suppose I'm telling you, when we ask the cues, if the examiner says that I am hearing a murmur in the left, where is this? In the left upper sternal edge, it will be pulmonary stenosis murmur usually, right? Here what happens, he's telling short murmur it is. Short means only some blood is entering with ejection here. It is not a long murmur, it's a short murmur. Some blood is entering here with ejection, and you also hear a ejection click. So when it closes, due to the vessel has become dilated now, you will also have pulmonary incompetence murmur here. But where is the position? I don't know. If anyone knows, tell me where you hear this murmur. It will be same like blowing character. It's written that it will be same like blowing character, but I don't know the position. Mostly in the tricuspid area.
So you are telling like aortic insufficiency murmur, you mean?
Yeah, same like that. Pulmonary insufficiency will be associated here.
So then it will be in the right side.
No, it's not.
We are talking about right pulmonary artery.
No, she's telling about aortic insufficiency.
No. Pulmonary insufficiency.
No, I'm talking about pulmonary insufficiency.
Pulmonary, then you will hear it left side.
Left side where? In the pulmonary area or below it?
They said third. They said the left side, third intercostal space, which I read from the
In the same pulmonary area. In the same pulmonary area.
pulmonary area.
P2.
What,
This.
Dr. Yasser?
Dr. Adnan, you know about Graham Steele murmur?
Yeah. It is the same that you are discussing.
Yeah. Tell me about Graham Steele murmur. Where you hear? I want the position. That's all I want.
In the pulmonary area.
This should be the pulmonary area. This is coming from the pulmonary incompetence.
Pulmonary area means the left second intercostal space only you hear this murmur.
Yes.
So we can hear both ejection and both blowing, early diastolic, both. If they give something like mixed finding like this, suppose they can give you the mixed finding like this, short ejection systolic murmur, and also you hear an early diastolic murmur together in the same position, you can think of Eisenmenger's if the child is not operated and he has cyanosis and clubbing.
But they will not give you this Graham Steele because this is very difficult to hear. Even big cardiologists, they are not mentioned.
I don't know, because this is this exam, no, they may just give you the cue to maybe I am telling you something mixed like this. You can put Eisenmenger's as the top. There are three chances here. One is the short ejection systolic murmur. It is short because the less blood is flowing here due to resistance. And there will be ejection click as well, ejection click and short ejection systolic murmur. And also you can have a TR murmur and a PR murmur like this. These three murmurs you can have in this case.
Yes.
And the clear child, a old child, clubbing, cyanosis. And also when you asked up to me, I should also tell about polycythemia, very important.
Yeah, you told this one.
You told the polycythemia.
Yeah. And educating the mother, I forgot infective endocarditis, dental hygiene.
Yeah.
All patients.
Yeah, dental hygiene should be.
Yeah, and even in management, also tell that if the child has any time infection, we should work up to rule out infective endocarditis because they are more prone for infection.
Dental hygiene, any infections, and any major surgeries.
Yeah. Means if he is going
like GI or genitourinary surgeries, if they are going, this is.
And if they have means there is one point here. If they think that it is not a site of infection, then it's okay. You can go without antibiotic prophylaxis. If you think that there is some infection in the site you are intervening, then you have to give antibiotic prophylaxis. This
Yes.
is in the Red Book guidelines also.
Yeah, yeah. This
So
is
others, this is from my side, and Dr. Adnan, you want to add anything, add, and also others can add now.
no, I think we have finished
I
this
think
one.
you completed
More than
Okay,
enough.
Dr.
Yeah,
Yasir, anything to add?
yeah, I will tell you one thing which I want to tell. And if there is any child who is coming with oxygen and all these kind of findings, especially, so then you should not only just consider of ECG, chest X-ray, echo, and some others, like you
Cardiac
have to
cath
check.
also you do sometime. You do cardiac cath also.
No, no, not apart from cardiac. I am telling, apart from the cardiac, you should tell about the CBC for polycythemia,
Okay.
LFTs, RFTs, serum electrolytes, and they may have hyperuricemia, can be associated with pulmonary hypertension. So uric acid and ferritin level, all these clotting profile should be done also,
So
because they have.
we should do these also with including the other X-ray ECG.
Yeah, you will tell that to confirm my diagnosis, I will do the echo and ECG, chest X-ray, and the child is already on oxygen and in hospital setting. So I would like to do some further test for for the management purpose, like CBC would like to see for polycythemia, LFTs, RFTs, serum electrolytes, and uric acid. That can be hyperuricemia in pulmonary hypertension.
Okay.
Then ferritin and clotting profile, they may have hemoptysis. So all these should be tell.
Yeah,
Also.
this the nearest differential for this is tetralogy of Fallot, because the
Yes.
cyanosis, they can also have this spells, cyanotic spells, polycythemia, hemoptysis, all these things, right?
Yeah, yeah.
So when you are not sure,
They
you
may have chest pain, syncope, shortness of breath, exercise intolerance, hemoptysis.
Yeah,
All these
hemoptysis.
things can be there. They may even have sudden death sometimes.
yeah, sudden death also. Yes, you're right. So these are the supporting investigations, but I don't understand why uric acid more, because of more RBCs production.
One is pulmonary, some which I remember when I studied this in my university. That was pulmonary osteo something was there, which I remember. So that's hyperuricemia is there. Pulmonary osteoarthropathy something was there.
No,
Yes.
maybe because of the increased production of RBCs and destruction will cause increased but uric acid is some purines.
We can check.
No problem. Okay, anyways, at least this is important, clotting, and also they same like tetralogy of Fallot, they are also more prone for thrombotic events.
Right side events, no? The right side heart issues, they will be having the more thrombotic events.
All cyanotic.
Yes, all cyanotic.
Yeah. So because of polycythemia, this is the reason.
Yeah, this is one possibility due to hyperviscosity syndrome. All this because this polycythemia, and other due to they can bleed easily due to platelet dysfunction, thrombocytopenia, and coagulopathy.
Yes,
also.
this is important also, platelet dysfunction.
Why they will have this platelet dysfunction? Any reason?
Because you
Yeah.
have more RBC production, and the platelets are like they are compensating your
Bone marrow.
blood when you are and this bone marrow is producing the blood. When you have more RBCs, the platelets production is less, compensating.
So you have to remember three things here: hyperviscosity and platelet dysfunction also, and thrombocytopenia. So they may have bleeding, hemoptysis like this, and also the cerebral thrombosis. So stroke can be the event, angina pectoris. They can also have sudden death due to this MI, or also heart failure. Right?
Arrhythmias.
Arrhythmias also.
Most common is arrhythmia.
That's
Heart
why
failure
they
will take some time.
electrophysiologists, they involve in this if they have arrhythmias.
Okay, fine. So yeah, we will add some other investigations. But when I was telling you ECG, echo chest X-ray, I thought I left something important. I was not remembering. I don't know.
No, no, no. That was.
Okay, now we will go to the
They are
next.
saying this hyperuricemia in adults usually.
Not in the children, doctor?
Yeah, most of the this I have checked this. I have in this PubMed. No, no, not this Medscape.
Medscape.
I have taken this from America, so I'm using this one sometimes subscription. So I'm checking on there. They are saying that this is mostly in adults.
And I want to tell you one more, Dr. Adnan. In auscultation, we forgot to comment on the S2. We should always comment on S1 and S2. When I told
Yes,
you
yes.
S1, S2, you should tell. This is loud S2 is very important here.
No, no, I told this one loud S2.
He
Maybe I
told
forgot.
loud S2. You can hear the loud S. He told you.
Loud S2 is very important, but I don't know if we can make out the pulmonary component or not. Some books gives, but it's very difficult. Palpable P2 and loud P2. How you can make it out? Anyone has auscultated like this?
No, no, no.
P2 is just like hammer. Somebody is
Yeah.
hammering, because if we got some patient in exam, so we memorize just somebody is hammering. Thuk, 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 continuous. So you consider this pulmonary P2 loud, pulmonary hypertension. Then we'll see. Because
But
here
you
they're very difficult to differentiate what is this, what is this. By
Yeah,
sound, you can just like memorize.
I am asking you, have practically any time heard or no?
Yeah, we heard. I heard.
In our center we are hearing the doctor, because in the cardiac
Come to
patients.
your center one day, yeah, Rehana, because I have.
I will call you. I will call you if there will be patient. I will call you. Come and listen.
Because I have not heard this difference really. S2, P2, all these things. Okay. Anyways, we will go to
Dr. Noor, I want to just clear one thing. According to the patient info, this calcium channel blocker, because they increase right to left shunt. So they are showing, have not been shown to be beneficial and may cause further complication like hypotension, worsening cyanosis, increased hyperuricemia and hemorrhage. So we are not using calcium channel blocker.
Yeah, in this hypertension, pulmonary hypertension or Eisenmenger, they are not using captopril. They are using sildenafil, as I see in our center also.
Okay.
Now, lisinopril is ACE inhibitor. This is calcium channel. This is like amlodipine, just like this.
wait.
What about this one? Sildenafil. Dr. Yasser, in your center, they are using sildenafil?
Here I don't, because I am working in oncology.
Where I was working before, they are using.
In Pakistan,
in our center also they are
is using sildenafil and bospon. They were using in cardiology.
No, in our center here Saudi Arabia, in our this is a tertiary hospital. They are using National Guard hospital. They are using sildenafil.
Okay.
I don't know about others.
Okay.
Yeah, go for
next.
Okay, next will be Dr. Yasser, role player. So I am out now. Now names. Dr. Yasser will choose the name now. So one will be Rohel and one will be Rehana, but you don't know who it is, okay? Okay, choose which letter you want.
B.
Okay, B is Dr. Rohel. So I will share the picture.
Next.
Next is the video station. Okay.
Video station.
Yeah.
Okay. This one. Maybe first time or second. Okay, I will try.
You will do it. Don't worry. But I will take some
mashallah.
Setting in an. Okay, no, I'll start. So I can see a baby, 6 hours old, in the hospital settings, and he's having some abnormalities. Like I can see there is fractural deformity of the limbs and the fingers, absent of the thumb, and in another there is imperforate anus, and in the X-rays I can see there are vertebral abnormalities, vertebral abnormalities, and the coiling of the NG tube as well.
Okay, anything else, or you can continue? So, Dr.
Yeah,
Yeah,
this
yeah.
one only. The flexural deformities of the upper limbs, absent of the thumb, and imperforate anus. And this one may be some hemangioma on the. No, I don't know this one.
Okay.
Okay, no problem. What history you want to ask?
So here, as the diagnosis in my mind, according to that, I would like to ask the first of all, I would like to ask antenatal history, especially for the uh, how was the scan during pregnancy, especially for anomaly scan during pregnancy, history of polyhydramniosis during pregnancy, and the age of the mother as well, and in the child, especially the history of drooling or excessive oral secretions, any respiratory distress, and history of cyanosis, feeding difficulties. All these will be at this age.
Okay. How will you investigate?
Well,
Examination, physical exam. What physical examination is first on then investigation?
yeah, on the physical examination, I would like to do the complete journal physical examination, and including the uh, skeletal examination and the musculoskeletal examination, cardiac examination, and as well as the renal examination and abdominal examination. So will be the complete examination should I would like to include.
Okay. What will be your differential diagnosis?
So my differential diagnosis in my mind is coming VACTERAL, as there I can see there are 4 anomalies which I have appreciated already. So in the differential, I would like to keep a Holt Oram, TAR syndrome, and Fanconi as well, and the Charge syndrome.
Okay. To diagnose vectoral, how many abnormalities should be there?
Yes, for as this diagnosis of VACTERAL is diagnosis of occlusion, and this is completely a clinical diagnosis, so there should be at least 3 features at least should be there, as this is complete form is vertebral anomalies, anal anomalies, and the cardiac tracheoesophageal fistula or any anomalies, and the renal and the limb anomalies should be there. So all these out of 3 features are there, we can label it as vectoral associations.
Okay. How will you investigate?
Yeah, well, for the investigation, as I told that this is usually a diagnosis of exclusion. So for general physical examination, if there are 3 features, we can diagnose. But still, to support my diagnosis, I would like to do like echocardiography, ultrasonography for the renal. I would like to do to put this NG tube and do some X-rays to check for the coiling of the NG tubes, and I would like to do for X-rays of the back as well as bronchoscopy can be done, and esophagogram can be done also, and to rule out other causes, genetic studies can be done also.
Okay. What are the cardiac lesion associated with vectoral?
Vectoral, they may have tetralogy of Fallot, or they may have I don't remember this, truncus arteriosus can be there, or there may have VSD also, which I have seen one
Okay.
patient.
And what are the renal abnormalities?
Renal abnormalities, like they may have this polycystic kidney disease.
Okay. How will you
And
manage this case?
for the management, as this is involving the multi organs, so I would like to involve the multidisciplinary team in the form of these child may need some surgeries. So pediatrician, pediatric surgeons, and cardiologist, urologist, and they have these skeletal problems. So definitely orthopedic, ENT, definitely geneticist, and social worker, and education of the parents, and the education of the parents, and community pediatrician should be involved here, ENT, and definitely developmental. They may have problems in the long run, developmental problems, and geneticist, and inform the GP as well.
Okay. What are the acute emergencies in vector?
Vector, mostly they are prone to feeding difficulties, choking, and respiratory distress, cough. All these can be there most of the time. So they may have drooling from this or excessive oral secretions, as I told earlier. So for that, this may be the emergency. They are not feeding, or they cannot swallow, or they feed is not going. They may have esophageal atresias as well. So this is the most emergency is there. They may have cyanosis also as well. And this is tetralogy of Fallot, as I told, but this may be present lately.
Okay. Time finished, but if you have any questions, you can continue. Okay. Okay, continue. You have
Okay,
any
no,
more
I have done.
questions?
I have done.
No, I think so.
writing.
He finished everything. If you have any other question, you can ask.
Oh, no, okay. Before that, you have anything which he told you want to add to it? You can add. Then I will give my comments. Like he missed anything of your questions? He did not ask completely or anything? Then I
Yeah,
will.
tricuspid atresia is not coming here. Only VSD, TOF, AST, and AV.
No, tricuspid atresia, I did not say. I said TOF, VSD.
Truncus arteriosus. Truncus
Truncus
arteriosus is not
arteriosus, I
associated.
was, yeah, this one is catch 22. Then I remember this.
Top VSD is the common with them. Top
Yeah,
and VSD.
VSD and TOF is the common. I thought maybe third one, that was catch 22 actually.
Okay. And the other thing is, despite of polycystic kidney, they have renal agenesis.
Renal agenesis, yes.
Agenesis, yes, agenesis.
Okay. What's the role of ENT?
ENT, they may have corneal atresias, so that should, if bilateral, that should be operated as well, which I remember. I don't know.
No, there is no association.
Okay.
And
Okay.
also you told geneticist also. No need here.
Geneticist, I was covering for this. If as doctor didn't tell me this is vectoral, so I was thinking of Fanconi, Holteram, and even if it is vectoral association, even if you are sure, even then they are doing the genetic testing also to rule out any other anomalies, any other problems. Even then they are doing.
Okay, yeah, but okay, I don't know this because
I don't know why I said this ENT. I remember ENT
Usually it
was
is
there.
multifactorial, na, doctor?
Yeah, this is multifactorial. I myself have diagnosed one here.
here in
myself.
the Gosh, I was reading today Gosh leaflets. It is very clearly written in the Gosh leaflet that when you explain, this was actually this leaflet was for communication. It was when you explain to the parents, you will tell them that the cause is not known, and there is no association with genetics and environmental factors. Okay. And also, what is the other thing? There won't be any similar condition in the family. So there is no genetic relation. This is what is given clearly written in that. But if, if this is vectoral, what is your role? Then don't set geneticist. If it is like generally, if you want to speak, no problem. Okay.
It's not.
No, that was yeah. I know this is multifactorial, but to rule out other causes.
It is considered as multifactorial. That's also I read it.
Yeah, this is they have written in, I think, info or somewhere I have studied this one. They are saying that we'll have to do the genetics to rule out other causes that may be the similar kind of association may have. So that's why I was thinking. Should
Okay,
we
no
include
problem, but
genetic history?
only this is the comment only if they
Yeah.
tell you in particular vectoral, don't tell. Otherwise, you can tell because your
And
different.
vectoral, one thing, vectoral associated with hydrocephalus also. But I did not know this is, am I right or not? So I did not tell this one.
I don't know. I did not see.
They
the-
have
Again,
association.
Dr. Adnan, again.
I don't know.
Sorry,
They
I
have
can-
association.
Hydrocephalus, vectoral associated with
Yeah,
hydrocephalus.
hydrocephalus association. Others are there. Hydrocephalus is
So
there.
I did not tell myself because I was thinking that maybe this is wrong or right.
No, is it associated? Other anomalies are there, but we have to follow the vectoral, the components as most common. Don't go deep more. Difficult ones.
So here the history will be mainly antenatal history only. Antenatal history of
This one, Dr.
This is
Noor, which
antenatal.
history points I have given, and I think Dr. Yasser will be agree. This is the most rightly I said. I
Yeah,
think
yeah.
so. Others I don't know because they may have anomaly scan on antenatal. They may have polyhydramnios. Young age mothers, they may have associated with this vectoral. Okay, then they may have on postnatal drooling or excessive oral secretion. This case came in our this Jeddah exam. This came the same case. He was drooling too much and he was cyanosed.
Yeah,
Okay.
excessive secretions, cyanosis.
Yeah.
So what else we can see? We can see
Yeah.
here.
The others you can see respiratory distress. They may have feeding problems, and if the child is old enough, then this will be recurrent pneumonias can be there because they have mostly GERD problems in the later on. So this can be recurrent pneumonias or asthma, chest pain, and you can see the surgical scars. They may have gastrostomy or fundoplication in the previous history, and the history of other surgical scars like on the skeletals, musculoskeletal areas or anal areas and other renal. So all these can be seen, but it will be in the old. Actually, I have seen this two patient. That's why I know one. I have diagnosed myself.
Okay, good. He had all this. How many out of six? How much he had? Three? More than three and more than three.
Which I have seen. He was having, should be at least three features. Three out of all these should be three. So which I have seen, he was having four. Another one which I have seen, he was having two only. So that was actually I know this family personally. He's from my same city. So I told them this may be, and they have studied already. Their parents are not doctors, and they have studied each and everything already on the Google. They are saying, doctor, these are not. I said this is incomplete vectoral. We can, and then he said that doctor also said this is incomplete vectoral. He's having only anal problem and he's having only the renal problem. Otherwise, no problem.
Oh, he was having main features only two. Main only two, but still it was.
Only two main features was there. There was no limb problems and there was no tracheoesophageal fistula. There was no other problems. And I told them you should at least should be done for echo and other things should be done. Maybe and this MRI of the spine, maybe he has. So they said that we will do. We will follow.
In the X-ray, you see here. You see in this picture. In the first picture, you are seeing scoliosis. You can see scoliosis here.
Scoliosis is easily.
Scoliosis. In this picture,
there is scoliosis.
Yeah,
and this vertebra.
There is vertebral break here.
We call it butterfly vertebrae.
Butterfly vertebrae.
Yeah, and above is this is sacral dysgenesis. This
below is sacral dysgenesis.
No,
this is not butterfly. Dr. Yasser, butterfly is a little bit different.
That will be in Alagille syndrome. Huh?
No, here you will have not butterfly. Here you will have some defects in vertebrae like this. Here there is no complete fusion here. It's incompletely fused, something like this.
This looks like the sacral agenesis. This looks like Dr. Yasser is right.
This up one.
Yeah,
Yeah,
up one,
yeah.
up one.
Up one is sacral
Sacral
agenesis.
agenesis. Okay, this is the some defect in the if you don't know,
Whatever.
What is this, Dr. Noor, which I was not getting this one? I have encircled this one, different color.
maybe some hemangioma. I am also
Yeah,
not.
this was, I was thinking maybe hemangioma. That's why I said.
Yeah, there is
But I'm not
absent
sure.
thumb. There is absent thumb. You
No,
told
no,
me.
absent thumb I told,
Yeah,
but
yeah.
hemangioma I was
Sometimes,
not.
And also you
sometimes
can
there
have-
are some pressure effects can also produce the same
Yes.
pressure, just like maybe they put pulse ox or something. In small babies, we have seen a lot of patients. They
They
put
may
pulse
have
ox,
amniotic
pressure effects.
Amniotic bands can also be there.
But
amniotic
amniotic bands, there
bands,
should be,
but there will be mark will be there.
yeah,
Yeah, that
Amniotic
will be
bands
having that
mark.
have marks. They will
Yeah,
have marks.
yeah.
Yes.
So now wait, we will go for our discussion now. So in the history, you said polyhydramnios, antenatal scans for anomalies, and
Yes.
age of the mother, young age can be there. And after
Yes.
birth, we have to see for respiratory distress, cyanosis, and feeding problems. They will have drooling and all those things.
Yeah,
Sometimes-
respiratory distress, feeding problem, and a little bit if 6 days, 7 days gastroesophageal reflux can be
Mm.
there,
Mhm.
and loss
But
of weight can
I
be there.
think if they have TOF, it will not be delayed till that day. It will be identified by
Yeah,
the
yeah,
first day only. Yeah.
yeah, definitely,
And
definitely.
sometimes they can also present with oligohydramnios and Potter's sequence because they are associated with renal agenesis. Okay.
Yeah, that one is Porter's. Yeah,
They can also present, like as you said, polyhydramnios due to TOF, like your case, which was incomplete. Means if he did not had TOF and there was some renal problems, renal agenesis, they can also come with oligohydramnios. So you have to ask about
yes,
polyhydramnios, oligohydramnios, antenatal scans, and even you can ask any maternal drug history, age of the mother, and immediately after birth. That's all the history comes here. Physical examination, better to say we will do head to toe examination to see the vectoral associations. Okay. If we can see anything. And apart from that, you said very nicely, complete musculoskeletal, cardiovascular, and abdominal examination. This comes here importantly, and if the child is in respiratory distress, even RS examination you can add. Then for the management, if this is 1 day old baby, right? 6 hours old, 1 day old, and you are also seeing some shining here. You can also comment on this. Okay, this the baby, it can be there is some edema here. Okay, and so here the emergency management will be ABC: airway, breathing, circulation, vital signs, continuous cardiorespiratory monitoring to see, and also the fluids, because the baby is not feeding. You should keep on IV fluids and arrange to shift the baby to the specialist center. If since here by this picture, you know that this baby has TOF, right? Tracheoesophageal fistula. So you will arrange.
There is coiling of the
Yeah.
NDT.
So you know that there is tracheoesophageal fistula. So start with airway, breathing, circulation, then vital signs, and then you will give the fluids because the baby is not able to feed, and you will discuss with your consultant and the respective specialists to
yes,
to shift. And at the same time, because of this limb abnormalities, you are suspecting vectoral, so you will discuss with the cardiologist and arrange an echo. And also if there is cyanosis and you are suspecting duct dependent lesion, you will start on prostaglandin. This also has to be mentioned. Suppose this baby is fully cyanotic, and if there is murmur and you are suspecting on examination, and if you are suspecting duct-dependent lesion, you will start on prostaglandin with respiratory monitoring. This much you have to tell. This is the emergency management in this case. The two things here is TOF and this cardiac comes main emergency. The other thing is they may tell you the opening statement as this is a child who has not passed his maybe 2 days, 3 days, like this, passed his meconium, like that also they can tell you. So in that case, if there is imperforate anus, you told already that you will arrange with the surgeon. This has also be these 3 things has to be done initially. The most priority will be if the child is in cyanosis and also you're suspecting a drug dependent lesion, prostaglandin also will come into play, and starting IV fluids, stopping anything from the mouth, nilpar orally, and
So
starting.
basically, we will start with ABC, Dr. Noor.
Yeah, and
So this is
and shift to the respective
center.
centers, discussing with the cardiologist. And for tracheoesophageal fistula, who? Pediatric
Surgeon,
This is
pediatric
pediatric
surgeon.
surgeon.
Yes,
Pediatric surgeon.
surgeon, and this, what is that?
No,
Yeah,
pediatric surgeon.
Two things, for imperforate anus and for the TOF, two things. Okay.
Yeah.
Like
Both
this,
will be
you
deal with
tell
the
the
both.
emergency, then you tell, after telling these 3 points, these 2 emergency for you, TOF and cardiac, you will also consider to make a stoma for imperforate anus. So you will involve your consultant and the cardiologist and the pediatric surgeon. Then you will tell all the other things. Okay, this was only one thing was my feedback. Regarding, I wrote some notes. I don't know it will benefit you or not. I will tell you about it. Yeah, okay, one question for you. So what about the mentality of these children? Are they able to read in mainstream schools or they need special schools?
I think mainstream school. But these all anomalies may have some psychological effect, but
yeah, yes, you're right. Children with VACTERAL association rarely have learning disabilities. So most will grow up and attend mainstream school.
yes.
Okay.
Okay, good.
So, and as you said, orthopedician for this limb abnormalities has to be involved. But I don't know, in our hospital and all, for spine, for everything related to spine, they involve neurosurgery. I don't know what is the protocol.
No, spinal surgery.
Spinal surgeon. We
are
Neurospine
dealing
only.
with spine only.
So in UK also it is like that, or we will tell orthopedic for the spine?
No, the spinal surgeon.
Neuro is the one that deal with that spine, or no other, there is separate spinal surgery.
Neurosurgeon will deal both with the brain and the spine, right?
Yes.
For us in our hospital, usually they will neurosurgery will follow. I don't know about you.
In our hospital, neurosurgeon will deal with both.
Here we have both facilities.
Mashallah.
But spinal are dealing with spine only. Neurosurgeon only brain and shunts mostly. Others, they don't touch anything. Okay. Second thing I just want to add, in charge, there is a low IQ level.
Learning disability is there in
charge. But here is normal. So just a differentiating point between both of them. Okay.
Yes. And regarding the commonest cardiovascular defects, is VSD is the most common, and second comes the TOF.
TOF, yeah, second is TOF.
TOF. And what are the vertebral abnormalities you see here? Just remember from this picture. This is, I am telling from my notes, I wrote it today. This is the scoliosis. Okay, this is also will be there, and also hemivertebrae. Maybe this is hemivertebrae, what he is showing here. Single or multiple hemivertebrae they can have, half vertebra. Okay, and also sometimes they can have deformities in the ribs. These 3 you see, vertebral, usually these 3 they are explaining. One is scoliosis, another is the hemivertebrae, and also some deformities in the ribs. Okay, anorectal, most common is the imperforate anus and some cloacal deformities. At least you should remember this. Okay. Then tracheoesophageal atresia with tracheoesophageal fistula with or without. Esophageal atresia is must, but TOF can be with or without. Okay.
Without, yes.
Okay. Renal anomalies. He asked you this question, I think. One is the renal agenesis. As I told you, sometimes they can present with Potter's syndrome. Then bilateral renal agenesis, the same thing, and they can have horseshoe and polycystic kidney. Okay. And limb, mainly here in the limb is the radial abnormalities they have. Sometimes absent radius, and dysplasia or deformities. Just remember, radial abnormalities are more common in the limbs, and also they can have polydactyly and syndactyly. And in here, as here radial, in the limb they will have tibial. In the limb, tibial deformities. Remember, in the hand radial and in the limb tibial. Okay, but anyways, radial is more common. It will be seen obvious for you in the pictures. Okay, that's all. So no clear cause, genetic or environmental cause is unknown.
So for the charge, this will be differentiating of the no, the one mental.
One is also coloboma will be there. Coloboma will be there.
Yes, coloboma will be there also charge.
No, and also some other things are also there, I think, right? Charge, I did not read. If Dr. Adnan remembers, can say.
Charge, I know there is a coloboma, but mental
They may
retardation,
have
I don't know.
genitourinary something. I which remember, I don't know.
No, they have, it's given in patient info, but I did not read. Okay. Tomorrow we can see. No problem. Okay. Now what? We will go for the next case.
Yes, next is Dr. Rehana.
Okay.
So Dr. Rehana and Yasser only is remaining. So I think Dr. You also did not do, sir. Who did not do now? Rohel
No,
did.
I did not do.
You did not do. So you will do next in the next. You will give to Dr. Yasser now. Okay.
I'll do the. You need one case for the.
Yeah, VSD. You have picture for you, VSD?
No, I don't have picture.
But you have prepared the case or no?
Yeah, I have case, but picture I don't have.
Okay, just I will message you something. Okay, you can start now.
Yeah. Good evening. I am Dr. Yasser, pediatric registrar, working in this hospital.
Good evening, doctor.
Good evening. I'm Dr. Yasser, working in this hospital. I think you are mother of Sam, and I want to first of all I have to wash my hands. Then I have to greet myself to the mother and also to the Sam. Sam, how are you? Then I have to see the surroundings, and then I have to see the facial features of the Sam. Any dysmorphism, I have to see for any respiratory distress, and then
no dysmorphic features, no respiratory.
dysmorphic feature. I have to see is the Sam is looking well or ill.
He looks well.
Okay, I want to review the growth chart if possible.
He's growing towards his 25th centile.
Okay, I want to see any monitors attached to him, any saturation.
No monitor.
Okay, I have to start from the hand first, and I made a exposure, and then after taking permission from mother of Sam, I have to see the hands to see any cyanosis, any clubbing, any pallor,
No clubbing.
any sign of infective endocarditis in the form of splinter hemorrhage, Janeway lesion, and ossular nodes.
No.
Okay, then I see the radial pulse. Then I have to see the volume and the character of the pulse. Then I have to perform collapsing pulse maneuver.
Pulse is okay, normal pulse, character.
Then I have to. Okay, then I have to compare the other hand radial, and the radio, and also to see the femoral to see any radial and radiofemoral delay.
No delay.
Okay, then I proceed with PP. I will take at the end. Then I have to go to the neck, and I have to see any raise of, I make any raise JVP.
No JVP raised.
Okay, I have to see the eyes and any pallor.
Mild pallor there.
Okay, any jaundice?
No jaundice.
No jaundice. Then I have to see the mouth, oral cavity, any about dentition and hygiene.
Yeah, he has some dental poor hygiene.
Poor hygiene. Okay. Then I have to examine the chest. I have to see the symmetry,
Chest is symmetrical both sides.
shape,
Shape is okay.
respiratory rate.
He's having normal respiratory rate. He's not in distress.
Okay. Any visible pulsation, any visible scar mark.
No.
Okay. Then I have to palpate both sides of the chest for the apex beat.
Apex beat is in normal, fifth intercostal space along the mid-clavicular line.
Which side?
And the left side.
Left side. Okay. Then I have to see the character of the apex beat.
Normal.
Okay. Then I have to palpate any visible pulsations.
No
Any
visible
thrill?
pulsation. No visible palpitations, pulsation, no thrill.
No thrill. Okay, I have to palpate in the apex area, tricuspid area, pulmonary area, and then right-sided aortic area, and also the neck for any palpable thrill.
No palpable
Then,
thrill.
okay, then I have to auscultate the apex with the diaphragm and to see how is S1.
S1 is normal, but he has murmur.
Where is the murmur?
Murmur is in the whole pericardium,
Okay,
overall pericardium.
okay, holosystolic murmur. And what's the character of the murmur? It is systolic.
It is pansystolic murmur, grade 3/6.
Grade 3/6. Okay, and then I have to auscultate the pulmonary area for this second heart sound.
Second heart sound normal.
Normal. Okay, then I auscultate the aortic area on the right side.
It's okay. Normal.
I have to auscultate the neck for any
No
radiation.
No radiation.
No radiation. Okay, I have to do the inspiration and expiration maneuver to see the intensity of the sound increase.
No, it is not changing with the expiration, or it is not changing with the position.
Okay, and I have to see the examine the abdomen to see any hepatomegaly.
Mild hepatomegaly.
Okay, then I have to see the pedal edema.
No edema.
I have to examine the back to see any scar, any
No
radiation.
scars. No scars, no back radiation.
Okay, any capitation on chest auscultation.
No.
Okay, and I finished my examination.
Okay. Present your case.
Okay, I have examined that.
You would. Yeah, he finishes case, and
Yeah, I
others-
just offer this blood pressure, volume of blood pressure.
yeah, this is what I was going to say. If
And
you finish-
I have to see the OFC, and I have any possible pulse oximetry is available. I have want to see the saturation of the chest.
Okay, doctor, present your case.
Okay. I have examined 7-year-old Sam, who is conscious and cooperative during my examination. He is not in respiratory distress and not having any dysmorphism. He has no sign of cyanosis in the form of no sign of cyanotic heart disease in the form of any cyanosis and clubbing. Although he is mild pain, and only finding he has there is his first cardiac examination. On cardiac examination, he has apex beat in the fifth intercostal space, medial to mid clavicular line, and the first heart sound and second heart sound were audible, and there is hollow pansystolic murmur heard all over the precordium, and of grade 3/6, and it's not increasing or decreasing with the respiration maneuver. the patient, there is also no evidence of infective endocarditis, and the patient having no sign of cardiac failure.
So what's your diagnosis?
It could be a case of ventricular septal defect, or could be patent ductus arteriosus.
Patent ductus arteriosus, and this pen systolic murmur, you will have patent ductus arteriosus without any scars or anything at this age?
Yeah, they can.
They can, okay. And how you will diagnose? It will be only the VSD, which type?
A small type.
Okay. And how you will diagnose?
First of all, I have to I will to do some investigation in the form of chest X-ray, electrocardiogram, echocardiography, and if possible indicated, then I go to for ventriculography.
What you will see in X-ray?
X-ray, we have to see the cardiomegaly.
Mm-hmm.
And we have to see the cardiomegaly only, and if any sign of pulmonary hypertension, then we will see the pulmonary artery, prominent of pulmonary artery.
There can be signs of heart failure also, no? You might have the congested lungs.
Okay.
Okay, then ECG. What you said, X-ray, ECG, and echo. ECG, what you will see?
ECG, we have to see the left ventricular hypertrophy in the form of R waves in V6 and S waves in V1. And these are the only findings we can see in ECG.
But as you said, small defect, what you will see in the small defects?
ECG will be normal.
ECG will have biventricular hypertrophy in the small defects, in small type of VSD. Okay, and in echo?
Echo we
will
can
be the diagnostic, yeah.
Yeah, echo will tell us the size of the defect and also tell us the pressure in the chambers of the heart.
Okay, and what about the how you will treat them?
We will need a multidisciplinary approach. We have to involve pediatrician, cardiologist, and dietitian. And if we have to see if the patient, as Sam is 7-year-old, and there is no other stigmata of pulmonary hypertension and heart failure, so we can continue with the on observation, and we put some medication, anti-failure medication, to prevent to develop pulmonary hypertension in the later of life, just like diuretics are ACE inhibitors.
So you will main is that if they are small, if they have small defects, you will follow them. You will give them high calorie diet. You will follow them in close follow-up, wait and watch, and close follow-up. Sometimes they get close by spontaneously. This is for the smalls, huh? And then if you have moderate to severe, you might have to go for surgical management, surgical closure. What are the indications of surgical closure of the VSD?
First of all, failure to thrive. Second thing, heart failure that is not manageable with the anti-failure medication. And the third is persistent pulmonary hypertension, development of pulmonary hypertension.
Which you can see in the form of what?
Sorry again?
Which you will see how you will see that they are going to have the pulmonary hypertension.
We have to see by clinically and by echocardiography, and also in the long run, if they are not manageable, they can develop Eisenmenger syndrome. So
yeah, you can also, yeah, you said very good. This, if they develop Eisenmenger syndrome, before going to the worst, you go to and close them. And also you can measure their QPQS. That is the pulmonary and systemic flow ratio. You see that if it is 2:1,
yeah.
if it is 2:1, then in that case, you need, if it is 2:1, it's okay. It's still okay. But if it goes higher than 2:1 ratio, then you need to close them surgically. As you said, also, if they go to the Eisenmenger syndrome, you will close. Or also, if there is multiple VSDs, you need to close them, especially the Swiss cheese type of VSDs, then you need to close them.
No,
And
they are not closing. In
no, the multiple
Swiss
VSD.
cheese,
Swiss cheese,
yeah,
they are not
multiple
closing?
VSD or Swiss cheese, they are not closing. They are doing PA bending for that.
Ah, yeah, sorry, they are doing PA band for them. Sorry for that. Yeah. Yeah, in the multiple VSD and switches, they will do PA band, and then for the large VSD, they will close, or if the QPQS ratio goes more than 2:1, then they will close. Yeah, correct. Thank you for correcting me, because I forgot this. And one more thing I wanted to ask, what was that? That's it. I think, yeah, if Dr. Adnan, you have any other questions? This much
Just
I can.
no, that is right. Dr. Yasser did very well.
You did very
PA
nice.
bending, there can be scar. Okay, always
Yeah.
remember, if the child is pink and he's not having any sternotomy scar, median sternotomy scar,
No,
and
he will
there
have
is a
lateral
lateral
thoracotomy.
thoracotomy scar, and he's pink. So
If
this
they
can be
did this for this multiple VSD or Swiss cheese VSDs,
yes.
they will have the PA bending scar in the left thoracotomy, right?
Yeah.
Which side? Which side?
Left side.
Left side.
Left side.
Okay.
Right,
Left side.
thoracotomy can
Right
be done
is,
also, PA bending, but most of the time they are doing left.
Doing the left, yes. Yeah, this is what I was going to say. Right also they do sometime for PA band, but mostly goes by the left. Right also you can do the BT shunt, PA band, but mostly they go with the left, the PA band. Sometimes they do. If they have the accessible difficulty, they will go to the right side. Otherwise they do the left. Also in ECG, we can see in the small defects, we can see biventricular hypertrophy.
Yeah, biventricular hypertrophy.
Yeah. In the others, you can see maybe the LVH only, but in the small lesions, you will have biventricular VSD. And you will mainly follow them further. You will give, as Dr. Yasir said, with the diuretics, ACE inhibitors, and nutritional support. These three main three for the small ones. Others, if they have, as Dr. Yasir said,
if they have small, and if they are not in failure, so we will not.
Hemodynamically stable. That's what I said. If hemodynamically stable and not having any concerns clinically, you follow them closely, watch them, and give these three: antidiuretics, this ACE inhibitors.
No, we will not give. No, we will
not
not
us,
give.
not us. For the cardiograph, of course. For the
No.
No, even
if they are not in failure, we will not give. We will give high caloric diet and watch and wait.
No, but here his Mark said, in the moderate, you will go with the
No, they are saying only if it is in failure. They are giving only that.
If the moderate
prophylactically, I don't think so. That should not be given. Prophylactic, why they need to? Because it's close up by itself.
That is the small, no? But if moderate, what you will do for them?
Watch and wait.
Watch and wait?
For how long?
But how long, doctor? They said the age here, they said here
if
age
they are
in
not
the
developing
mark.
any failure signs, that even close at 8 to 10 years, 12 years.
No.
But here in the mark, they wrote maximum
Doctor,
2 to 5 years in the mark.
4 years.
Usually 2 to 5 years, even sometimes 8 to 10 years they close. Usually they have written 2 to 5 in mark BT, and for if they have.
So what is the age criteria then? I will also
if they have some problems, then we will have to less than 6 months can be closed. And if the child is
even if the child if the Down syndrome, 3 months.
Yes, less than 3 months they are closing. And usually it's closed for surgery. They are doing at 2 to 5 years if required. Sometimes they are even waiting for that.
So sometimes even they wait, even you go for up to 8 years, huh?
Ideally, 95% close at the age of 4 years.
Yeah, usually close.
So that's the reason they put 5 years at the cutoff value, because later they will develop the pulmonary problems.
Yeah,
and that
this is
difficult to manage.
But I don't know one thing, why if they don't have failure signs, why they will give prophylactically anti-failure?
To
I don't
avoid
know.
this pulmonary hypertension.
Yeah, to avoid this pulmonary hypertension, because it's
Because
written
this-
in.
No, that's I understand. But if still there is no, then what will be the effect? Anti-failure is only in the failure. That's why we are saying anti-failure. Prophylactic role, I don't know. This I will have to check.
So Dr. Rehana, now it is, see, it is a small VSD. You will just follow up the child with high calorie diet. Okay.
Yeah, that is small VSD,
For
but I'm
this,
talking about.
we will keep the
Moderate,
question mark.
moderate.
We will check whether we will give this anti-failure or not. We will keep question mark that one. So high
Yeah.
calorie diet and follow the child. For
High
moderate,
calorie diet and follow, that's it.
okay, then for moderate, what you are doing?
Moderate, they said, if it is, if the growth is normal and no medical management is required, they may have surgical repair at age of 2 to 5 years.
Okay.
For very small defects, they keep wait and watch.
Okay, small defects can be waited and watched because they will not have any symptoms and they are growing normally.
But
And
moderate, they mention here moderate, if growth is normal, no medical medical management is required, then they can have surgical repair at 2 to 5 years. That's
5
what they
years.
wrote.
Okay, for severe, like AVSD or big defects, large defects.
They will, sir, they because they will hamper, if the large, they will also have the growth problems, they will be failure to thrive, they will correct them surgical repair.
I think within first year, right?
Yes, within 6 months they wrote it. 6 months here for the normal, but if it is Down syndrome, less than 3 months even they go for the surgical correction.
Because also I read today in Eisenmenger, the Down syndrome are more prone for to develop Eisenmenger.
To develop Eisenmenger, yes. I also read in the mark that they can
at an
develop
early age. Maybe this is the reason. And also the Downs may have, the more common presentation of Downs is AVSD, which is a large defect.
Yeah, this is the common for them. Down has AVS, this
And
AVSD.
can you tell me again about this pulmonary and systemic ratio?
Pulmonary and systemic ratio, that is if your QPQS, that is pulmonary to systemic flow ratio is 2:1, then it's okay, still you will follow them. But if it goes like higher than this, then they need surgical correction. They will do this by cardiac. Sometimes they are observing them now, following them. If they feel like they need.
2:1 means what? The blood is going 2 times more in pulmonary than the systemic?
Yeah, the ratio from pulmonary to systemic is 2:1. If pulmonary will be 2 and systemic will be 1. If it is higher than this, then they will correct it. Because your pulmonary flow will be high from the VSD, no? So if it goes like more than that, more than this ratio, they will correct.
Okay, okay. Good. Okay, and another important point we have to remember is for Swiss cheese and multiple VSD.
Yeah, that's that
For
one I
that, you
missed.
can see just a lateral thoracotomy scar. Okay.
Yeah, you will see PA banding, you will see the lateral thoracostomy.
VSD in the exam has come as an video station also, and also for the clinical station. And I have one comment for Dr. Yasser. If you have any comments in the examination, you tell
He
first.
did examination very well.
Okay. When she told the pansystolic murmur is heard everywhere, you should ask her where it is loudest.
Where it is louder. Where is it louder?
Because definitely they will tell in the exam for you, we hear the murmur everywhere. Then you have to ask where it is loudest.
Where it is loudest.
I have this question from you. Then she will tell in the lower left sternal edge.
I will tell it is maximum heard in the left lower sternal border.
Left lower sternal edge or sternal border, whatever she will tell. Then you will ask for radiation. Okay, what
he asked radiation, he asked variation.
But he did not ask this question louder. You told all over the pericardium. This I am telling.
Yeah, this is if he told me that where is it louder, I will tell maximum in the left lower sternal border.
Yeah,
I just one thing will tell. Dr. Yasser rightly said this one prophylactically, because most of the cardiac they are doing, but we will have to search.
No, in our center also they are keeping them in the furosemide and captopril.
They are starting from the birth even.
Yeah, our patients from the birth they are on. If they have VSDs.
But we
My
need source. We
cardiologist,
need source.
yeah, my cardiologist, he was also starting. But we'll have to check this one. We should start this. I mean to say guideline what they are
Yeah,
saying.
it's even in the mark written, no? But they did not mention here age. We have to search for the age, when
Yeah.
they are starting. We have to search for the what time they are starting. We have to look for that.
Okay.
Okay, what will be the agenda tomorrow?
Tomorrow, yeah, good question. Let me
Tomorrow she has general meeting.